Welcome to the Post-Acute COVID-19 Exercise and Rehabilitation, or PACER project. This presentation is Pulmonary Rehabilitation Post-Acute Care for COVID-19. Here are our disclaimers. This is for educational purposes. Bios and disclosures. So Pam Bartlo, you can see, has been a PT for over 23 years, is a board certified specialist in cardiovascular and pulmonary PT since '05. I teach full-time at Gville College and work in outpatient pulmonary and cardiac rehab. And I am vice president of the cardiovascular and pulmonary section of APTA. Naomi will introduce herself.
I am a board certified specialist in cardiovascular and pulmonary PT as well. And I focus on outpatient cardiopulmonary rehabilitation. I work full-time in that setting. I am a member of the nominating committee of the cardiovascular and pulmonary section of the APTA.
And neither Naomi or I have any conflicts of interest to disclose. So there are the objectives, and you can read through them. I'm sure you've read them prior to this course as well. And I'm going to start, and I will be starting with rehab considerations for post-acute PT with the COVID-19 patient. So at this point, we don't have a lot of data on COVID-19 survivors' presentations and their rehab needs. There is some data that's starting to be collected. There are several projects we've heard about that are starting to go on looking at some outcome measures and some functional capacities for people with COVID-19. But at this point, there still is almost nothing that is published. It's all anecdotal. The data that's published was really more on the characteristics of diagnosis and not necessarily their presentations of rehab needs. So much of what we're going to go off of is really from our ARDS data, or our respiratory distress data. Using some of that data, the post-acute presentation, whether that's home health or subacute rehab or possibly outpatient when they get to that point, the things that really impact it the most are going to be the length of time on the vent, the number of days in an ICU, how much sedation did the person have, and then some of the stuff that is starting to come out anecdotally specific to COVID is about the function at day 7 after extubation. As we know, and as you might hear in other lectures, physical and cognitive deficits are both going to be possible. From the ARDS data, that first 2 months shows the greatest time for recovery. We think that might end up being even a little bit longer for COVID-19 survivors, but it kind of depends on how severe their presentation was. People that were longer in the ICU, longer on the vent, they might take 4 months before they're really showing their greatest levels of recovery, versus somebody that maybe was not even hospitalized, they might really show their recovery within 2 months. So at this point, though, what we're seeing, the people that have COVID-19 are showing greater levels of weakness and endurance, and that it tends to be severe and progress slowly. So we're going to talk first about some of the primary goals for a post-acute PT with the COVID-19 patient. So these are sort of the 4 goals that we think are really the primary goals to address with PT for this patient population. Endurance being the biggest of those. The patient may have had prolonged hospital stay. They might have signs of ICU-acquired weakness or PICS, post-intensive care syndrome. They are almost assuredly going to have dyspnea and O2 desaturation. There is almost no one with this disease that is not showing some dyspnea, and very few that aren't showing O2 desaturations too, especially if they were hospitalized. Strength seems to be a big issue, and we'll talk about that more specifically in a minute, of how this is different than some of our other pathologies. Independence. A lot of these patients are being discharged very early because we want to free up hospital space in case the quote unquote surge hit. The other thing is they want to get people out of the hospital as soon as possible to cut down on any other complications from it. So they may not be fully independent. The other thing is they might come to your home health, to your subacute or your LTAC to get independent because they couldn't go straight home. Safety is also an issue, and we'll talk about that a little bit more too. So endurance first. There is one study that came out of Wuhan looking at sort of the hospitalization days and relating that to endurance and some of the issues. So in this first study, this was again earlier on in the disease process in Wuhan, the average length of stay was 28 days in the hospital. We really don't have US data that's been published yet. I think it's varied around the country. There are some places where people are in the hospital 2 days. There are other places they're in the hospital 3 weeks. I think it's just going to vary, but we don't have anything concrete yet. Many are showing signs of ICU weakness and PICS that we talked about. Really, it's a moderate to severe decrease in endurance. almost everybody, even those that aren't being hospitalized, are showing decreased endurance. And so the longer that they were in the hospital or the more severe their presentation was, the more we're seeing the endurance is impacted. So endurance is really the biggest goal we're going to have to work on with these patients. Dyspnea and high respiratory rate were also shown to be predictors of that severe disease or death in the Wuhan study. And so even though we're sort of past the really critical stage with most of these patients by the time we're seeing them post-acute care, it is important to still think about that this dyspnea and high respiratory rate are symptoms that we really need to get under control so that we don't run the risk of the person having further complications from the disease. So much of our pulmonary rehab is going to be focused on endurance. As I said, that's really going to be the primary goal. So we're really going to need quantifiable assessments of endurance. And this is something I've been pushing in general with cardiac and pulmonary care for the past several years, is really looking at quantifying our endurance. When we talk about interventions, we're going to talk about needing frequent rests and then working towards longer durations. And Naomi is going to actually talk specifically about goals a little bit later in this talk as well. Some quick general notes about oxygen. Many, if not most, of the patients with COVID-19 will require supplemental O2 in the post-acute rehab stage. If they were never hospitalized, they may not, because they may not have gotten to that severe lung state. But people that are hospitalized, most, if not many, are going to come home with supplemental O2. So our goal is to wean them down off of that O2 as we can. And so we're going to really need to watch O2 saturations, and Naomi's going to talk about that a little bit further. Because some of the preliminary observations are showing that the saturations might actually be underrepresenting PO2 levels. So what we're showing on a pulse oximeter, and let's say they're down around 90% saturated on the pulse ox, their PaO2 could be even worse than that. And we're starting to see with COVID-19 that those values might not match up, that the SaO2 or that pulse ox might underrepresent the severity of their lack of oxygenation. So we'll have to kind of look at that a little closer. I also included a resource here for you, the guidelines on supplemental oxygen. It's not specific to the COVID-19 patients, but it came out a few years ago. It's actually a really great resource that you might want to use if you're not as familiar with how to work with somebody with supplemental oxygen to get them off of it. So I talked about strength a little bit. Now I want to talk about, I talked about endurance a little bit. Now I want to switch and talk about strength. So prolonged bed rest and immobility, we know is a big issue with anybody. I did want to alert you to the fact that there is another PACER project specifically on PICS by Patricia Otaki and Jim Smith. So definitely make sure you check that out if you're seeing patients that are really coming to you with a long ICU stay. It's a really great talk that'll help you with those information as far as PICS, because there is more than just strength issues that we would see. With COVID-19, what's been interesting is the anecdotal evidence we're seeing from people is that the muscle mass loss is even greater than other types of ICU pathologies and bed rest. So let's say somebody had an ARDS and was in an ICU for 5 days, and then somebody had COVID-19 and was in the ICU for 5 days. We're seeing a greater loss of strength and possible actual muscle mass loss with somebody with COVID-19 than we did for somebody that had ARDS. So it's going to be very interesting to watch as the data starts to come out over the next month and two, maybe even up 6 months, because we got to try and figure out why that is. Some of the theories as to why that strength is changing so much more is it could be specific to the COVID-19 viral load. The loads might be higher than some of our other pathologies. It could be because the impact of prolonged lack of oxygenation to the muscle tissue. It's a little bit different even than just ARDS. Or it could be a physiologic reaction to the longer periods, as well as the increased respiratory rate and heart rate. So it's kind of a combination of that lack of oxygen, but also the fact that the body's running in a higher state of accelerated respiratory rate and heart rate, putting even more stress on the body. So when we talk about dealing with strength, we're going to really assess strength values. A lot of our traditional gradings are optional, or our traditional grading is what we want to use. So your regular manual muscle testing for muscles, standardized tests for functional strength, and we'll get into those. And I put one quote there. This is from an international committee that was looking at post-acute COVID-19 rehab. They really said it should be assessed and subsequently treated during all rehab for these patients because we're seeing such great strength changes. Independence, as I said, we really don't have a lot of data on this at all yet. I assume, based on kind of what we're seeing, that it's probably even a little bit higher than usual to send people home that aren't 100% independent, just because we want to get them out of the hospital, free up space. The other problem originally happening was subacutes and long-term cares weren't taking people with COVID. As my last bullet says there, this has started to change over the last probably 2 to 3 weeks. A lot of facilities are starting to open up a specific COVID wing or a specific COVID facility for subacute and LTAC rehabs. So obviously the need must be there that these people are not fully independent, and we can't just rely on family at home to take care of them. So it's going to be kind of a combination when we're talking about independence. Some of it might be they've been sent home and they're not independent yet, and we're working in home health to get them independent. Some of it might be at a subacute or an LTAC where we're trying to get them independent to go home because the family couldn't take them home otherwise. So how are we going to deal with the independence? Functional mobility testing, we can use our regular person ambulates with contact guard, or person performs transfers with min assist. Like, those standards are still very acceptable and really are desirable because they are very valuable resources or quantitative measures that we've used for years. So definitely when it comes to independence, don't veer off of your general, how much level of assistance, those kinds of types of things for your functional mobility. But then you might want to just augment with some of the standardized tests. You also want to try to minimize family support needed at home. These families are dealing with a lot of things. Some of them might be trying to isolate themselves a little bit from the patient. Some of them might be dealing with the illness themselves. And so we want to try to get the person as independent on their own as we can. Safety goes along a little bit with independence, as we all know, but the biggest thing here is we're going to really have to assess their safety concerns a little bit more than we would with some of our other patients. So that could be with mobility, endurance, balance, all of that. But remember, they might have cognitive issues as well. So the PICS and the ICU acquired weakness, there's also some cognitive changes that go along with that. Depending on how long they were sedated, there's usually some cognitive changes that can happen when people are on prolonged sedation because of a ventilator. So we're really going to need to look at some of those conditions as well. There's also some really interesting stuff starting to come out of the neurology section of APTA, where they're starting to see that there are actually some neural changes that are possibly similar to stroke patients. And so we have to kind of watch that data, or that observational and/or research data coming out, to see where we are from a neurologic standpoint with patients as well when it comes to safety. We're definitely going to teach them self-monitoring, and Naomi will talk about that. And as I said, we'll talk about standardized tests, and Naomi will also cover some interprofessional collaboration a little later. So I wanted to talk about now the functional capacity testing. So these are the really general, more functional tests. And this doesn't matter whether you're in a subacute or an LTAC, or whether you're in home health. SPPB, hopefully you're comfortable with that one. This will look at standing balance, gait speed, and sit to stand. You don't need any specific equipment. You can do it right in a patient's room or in a patient's home. Remember, for a lot of these patients in subacute and LTACs, you might be confined to treating them in their room with the door closed. This test can be done there. Might have to do a little bit of modifications, but it can be done there. Sit to stand tests. There's a 30-second sit to stand. I didn't include the 60-second, but there's also a 60-second one, or you could do the 5 times sit to stand. And then also look at your regular mobility assessment. So ambulation distance, or their transfer status, level of assistance needed, those kinds of functional tests. Outcome measures, I'm going to talk a little bit about now, but I did want to refer you also that there is going to be a poster presentation on cardiopulmonary outcome measures by Kristen Lefebvre. So look for that one coming in the next week or two, because she's going to go into much more specifics on the outcome measures. When you go to do the outcome measures, decide what's most appropriate for that patient. Are you in subacute LTAC? Are you in a home health? Are you still in an acute care setting? I mean, this is geared towards post-acute, but you might still be practicing in an acute care setting. So what equipment do you have? If you're in an subacute or LTAC, as I said, you might have to be with the door closed. So what can you fit into that room? 2-minute walk tests, 6-minute walk tests are on there because these are great tests. If you can get the space and if you can get the patient ability to do those. If you can't, a step test works great. There are a bunch out there. The Astron rhyming one is the one I've put here because it was shown to be the best with pulmonary patients. Now, that research was done with people with COPD and not a restrictive pathology like COVID. So I can't say it definitely would be the best for COVID, but you can take any of the step tests and sort of modify them too, as long as you really write out how you modified it and then use that same modification for both your pre and your post test so that it'll work as an outcome measure. The tug, you're timed up and go. This is not a true endurance test, but for people like this that are very lower functioning endurance wise, it's a really good test to give a measure of functional endurance. Modified shuttle run tests, we're used to the traditional ones where you were running with the beeper. Obviously, none of these patients are doing that, but you can do a modified shuttle run, and there are a bunch of different protocols out there. If you're in a subacute or an LTAC and you have the ability to still use the gym, you could do a recumbent stepper test. You just have to make sure you completely are disinfecting everything. But I think some of these other tests are just as good that maybe for this population, it might not be worth the risk of having to do all of that. And then there are others, as I said, Kristen will discuss more in depth. I did want to give you two other references that have become really cool things to use for outcome measures. So the Home Health Toolbox, if you are a member of a section of Home Health, it's free. If you're not a member, anybody can buy it for $25. And it comes with all the measures, the grading sheets, all the references for the age norms right there at your fingertips. It's got so many outcome measures, way more than I've even covered here. And you don't have to just be doing home health to use this. If you're doing subacute or LTAC, or if you're doing even an outpatient, you might use some of the tests in there. The other one was an app that was developed by a PT. It's called the Therapeutic Outcome App. I get nothing, no profit from this. I'm not trying to, make money off of this. I have nothing to do with this. But it's on iPhone or Android. It's $5 for the app. It's just a really cool app because, again, all the outcome measures are in there. You can get all the protocols, what steps to use, but you can also, certain ones, you can plug the patient information in there and use the app to kind of give you their outcomes as well. Then there are the clinical signs or clinical methods to evaluate endurance. So all your general observation things, how short of breath are they? What's their pallor look like? Or are they red from breathing too much? Things like that. What we are seeing so far with patients with COVID is that their baseline dyspnea progresses really quickly. So with little bits of functional activity that somebody else might do, they're getting very short of breath and decreased O2 saturations quicker than somebody else would. Positioning and posture are other things to think about when we're evaluating endurance. Does it take a lot of energy for them to even just hold themselves up? Toleration of therapy, how many rest breaks do they need? How long are they taking for their rests? So some of these you can make objective, some of them can't, but they help to qualify that endurance. We want to quantify it as much as we can with those outcome measures and that functional endurance and their level of assistance, but we use some of these other clinical observations to qualify that. So we can say, look, they ambulated this far, but they needed this much rest. Their dyspnea was this, they showed this on the pulse ox, and use kind of all those things together to form your picture. Breathing pattern, it's a bonus if you remember the names. I don't really care if you remember the breathing pattern name. What I care about is, do you realize that they're having a high effort of breathing? Could it be easier for them? Are they breathing in an inefficient pattern? That's what I want more than I care if doorstop versus diaphragmatic breathing. If you don't remember the names of the different patterns, it doesn't matter. You're really looking at what is their effort level and how could I improve that? Functional mobility, we already talked about all those and how to make those measurable. Adaptive devices and equipment, just look at the quality and efficiency of their movement. Remember, every device will require a little more energy expenditure. And so the person then might have more physical needs using, say, an assisted device because they've got to use that device as well. That takes energy. And so they're going to get a little more short of breath from that. Environmental accessibility, you want to just look and see the way they're doing things. Is that the most efficient, or is there a better way that they could be doing things? This is a little schematic that I like because it kind of, to me, reminds us the really full circle between endurance and mobility. So if I have more endurance, I'm going to be able to be more mobile. But at the same time, I can't be more mobile unless I have greater endurance. And so it becomes this thing that every part impacts. So if I'm less mobile, it's going to take more strength to do that mobility, which is going to make me more fatigued. If it's a strength issue, if I'm a little weaker, I'm going to get fatigued quicker, so I'm going to be less mobile. If it's an endurance issue, I'm less mobile because I get so tired, and because I'm less mobile, I start to lose muscle mass, I lose strength. So that's why it's important to really focus on all three of these things, because they really build off of each other. If you make an improvement in one area, it's automatically going to improve those other areas. So as far as endurance and mobility, there are way too many studies here to show how positive it is between improving endurance and mobility together. So far, there's none specific to COVID-19, but we have no reason to believe it won't be the same. That as you improve endurance, you're going to improve mobility. And as you improve their mobility, you're going to improve their endurance. All right, and so that's kind of what I just talked about on that last slide, how interdependent they all are. I'm going to switch now a little bit and talk about some exercise prescription. We're going to focus here on home health, subacute, and long-term care. I will mention outpatient in a few minutes, but this part's really focused on those areas. So some general considerations to think about. Supplemental oxygen, did they use it prior to COVID-19? As I said, most, if not many, will use that oxygen coming home, but we gotta know, did they use it beforehand? If they did use oxygen prior to COVID-19, we're not gonna get them using less than they did before. They're probably gonna use at least equal to that, not more now, and they may desaturate even more now. If they never used it before, our goal is to try to wean them off of it. It might take a few days, it might take a few weeks. One of the big things here is that as PTs, we really want to enable ourselves to make that clinical judgment. And so what we need is an order that allows for titration of oxygen. Now, some states, I do realize this might not be the case. I practice in New York State, so oxygen is considered a medication. We need an order in order to titrate it. If the doctor just writes that the patient's on 2 liters of oxygen, I cannot change that 2 liters of oxygen. If the doctor uses an order similar to what I've given you here, then I can change that oxygen. So that you can create this yourselves too, and then ask the doctors to sign it. So is it continuous all the time? If they sign that, you can't take it off the person. They're gonna have to leave it on. If it's as needed, you can then titrate it. The bottom part, that oxygen prescription, is the biggest thing here. This is where it's great, because if that very last bullet is where you can get that leeway. So if they're willing to check off that box and write in 0 liters to whatever they're currently on. I mean, some of these patients are still going home at 10 liters of oxygen, which is unheard of in the past. But, you know, this would give you that ability that if they're normally on 2 liters and you start exercising with them and they drop, you can increase it to 3 liters or 4 liters as needed, or you can start to decrease it as they get better. So if you can get an oxygen titration order, regardless of what setting you're in, it's going to make you much more able to use your clinical judgment as you're exercising with someone. And these are some of the general considerations that Naomi's going to cover a little bit later. She's going to talk also more about the modified Borg scale later. I just wanted to include it here because a couple of the recommendations that have come out from some position papers for COVID-19 so far do talk about using this scale. So now we're going to talk specifically about some of the exercise. So aerobic exercise. I have no brand new information for you how this is you treat your patient. You're going to use the same modes you've already been doing. Ambulation, stairs, you know, if you have pedaling available, great. If you're in the patient's home and they have other equipment like treadmills or bikes, you can use it, that's great. You know, intervals are going to be a big thing here. So that's what we're going to really want to focus on. And so Naomi's going to talk about that, but HIIT is probably not what we're going to use early on in the post-acute care because it's an increasing the likelihood of droplet expulsion. And we could therefore possibly continue to spread the virus. At this point, we still have no concrete information of how long that person is contagious for. There has been studies that have shown anywhere from 6 to 8 weeks that the patient is still showing viral shedding. How contagious is that? We don't know yet. So at this point, we're trying to limit the things that would create droplet expulsion. And so we're going to try and keep it, and that's that third bullet there, the intensity. This came out of a position paper from the Europe, mostly the UK, where they're really recommending that we stay with lower intensity exercise that first 6 to 8 weeks, partly because of the person's physical capacity, but partly because of we don't want to increase that likelihood of creating a bigger cough, thus creating that droplet expulsion, or creating very heavy breathing that would create that droplet expulsion. Frequency is going to depend on your setting. You know, if you're in a subacute or an LTAC, you might be able to see that patient 3, 4, and even maybe 5 times a week. If you're in a home health setting, you might not. One of my colleagues was talking to me the other day. She has a patient with COVID-19 that she's allowed to see him once per week because of a PPE issue. So it's just going to vary. It might also vary based on their presentation and their abilities or whatever your agency policy is. So try your best to make your clinical decision for what the person needs, but realize you might have other things impacting that, especially with a PPE issue. I know what you're all looking for is these clear-cut guidelines of this is the vitals you want, and that's when you do it. You know, at this point, we can't tell you that yet. There just is not enough information on people with COVID-19 yet. We also are seeing so far a lot of variability. So this is when our value as PTs is really going to shine, because we all have that ability to do clinical assessment and clinical decision making, and we're going to exercise that at its highest level here. So you're going to need to really individualize your care with your patients based on what they look at. You can also use their vital sign responses, their symptoms, and Naomi is going to touch a little bit on parameters as sort of our broad guidelines, but this is where you really get to show our abilities and our skills at assessment and decision making. Strength and resistance. You're going to want to focus on functional movement strengthening. So all your stairs, sit to stands, pushing and pulling things, then get into your body weight stuff like lunges and squats, whatever the patient can do. You know, if I have an 82-year-old that was hospitalized for 2.5 weeks, I might not be doing tricep dips and squats and things like that. If I have somebody that, you know, was maybe hospitalized for 3 days and they're 66, then maybe I can do some of those kinds of things, especially working into some of those modified planks, quadrupeds, some of those higher level core types of positions. You have to just go with what your patient can do. And you guys kind of know that. One thing I found interesting that we're hearing anecdotally from people is that a lot of the patients are having more core and small muscle weakness than large muscle weakness. A lot of times when we see people with prolonged bed rest, we see a lot of the lower extremity muscle wasting and issues with that. A lot of these patients, they could be on a ventilator for 2 weeks, they stand up and their leg muscles are fine, yet their core and their upper extremity and some of the smaller muscles in the legs, like the calves and the ankle muscles, are weak. So you're going to have to kind of make those decisions and see, is that something we're really seeing or not? If you can add in weight, that's great. At home, just like you would with home care, add in whatever weights you can. Try to use what they have in their house so that you don't have to bring things in that you then have to sanitize. If you're in a subacute or an LTAC, try to use things that are easily sanitized. So kettlebells, metal dumbbells, things like that that can get wiped down really easily. The ankle wrist weights, machines, things like that, only if you can completely sterilize them, because they're a little bit tougher to sterilize a lot. So your kettlebells, dumbbells that are a little easier to just go over with wipes might work better. Now I'm going to touch, as I said, a little bit on outpatient. At this point, we're not really sure when the bulk of outpatient pulmonary rehab programs will be able to reopen. People are trying to do some telehealth right now, and we're looking at some programs of possibly trying to open up some outpatient pulmonary rehab specific for people with COVID and not even our traditional pulmonary, but we're just not sure at this point. And at this point, if you're truly going to bill as pulmonary rehab, there is no reimbursement for telehealth yet. There is for some PT, depending on where you are. And so that's a possibility if you can evaluate and bill under PT. But for the G codes related to pulmonary rehab, at this point, you can't bill for telehealth. Some considerations as we start to think about outpatient in the next few weeks. How long since the person was diagnosed? How long have their symptoms been resolved, or when were they discharged from the hospital? We're going to all have to think about, do we mix people that are COVID positive with non-COVID patients, even if they're not even symptomatic anymore? So this is going to be something over the next few weeks or a month as we start opening things back up. Do we do that? When we had our traditional people with COPD or IPF in pulmonary rehab, do we mix them in with a patient that's COVID positive, even though it's been 4 weeks since their hospitalization? You know, these are all things that we just don't have concrete answers for you yet. We are hoping in the next few weeks that somebody will have a little bit more information that we can then offer something specific to outpatient. But at this point, this is the best we can kind of tell you is these are considerations that you'll have to think about if you're trying to reopen your pulmonary rehab. Aerobic exercise will follow just the traditional pulmonary rehab. This is again talking about outpatient if and when we get there. It's going to follow sort of traditional pulmonary rehab where we'll increase the duration first and then intensity as we can. They're probably going to need higher levels of supplemental oxygen than our traditional pulmonary rehab patient did then. For resistance, we're really going to try to focus more on weights. A lot of our pulmonary rehab patients can use strengthening, but they're not going to have the loss of muscle mass the way our patients with COVID do. So we're going to really have to focus more on resistance and strength for our people with COVID than we do for our traditional pulmonary rehab patients. Once we get more towards an outpatient, that's when we might start looking at the HIT strategies, but we're just not really sure yet. And as I said, Naomi will kind of touch a little more on specific parameters. Everything is going to still be very individualized, though. It's really going to depend on their age, their hospital stay, their progression since discharge from the hospital. So it's going to be much more individualized even than some of our traditional pulmonary rehab was. So these next few slides, these are all my references. Some are very specific to things that I covered on there. Others are more related to just some of the information that's on there in general, especially when talking about the outcome tests. And now I'm going to go ahead and turn it over to Naomi.
All right, so as Pam mentioned, I am going to talk somewhat about parameters. So we'll go ahead and get started with that. Unfortunately, we don't really know exactly what the ideal parameters are for these patients. There's obviously a lot of information out there about how they're presenting, but there's no research, there's no studies saying these are the types of parameters that we should be using. Anecdotally, we do know that their activity tolerance is very low, especially if they've had an ICU stay. We're seeing that significant activity-induced hypoxemia that Pam mentioned, likely primarily with endurance-related activities such as walking. The patients are quick to fatigue, so they're going to need slower progressions and more rest breaks than a lot of our other patients. The muscle weakness that Pam mentioned as well. We're not necessarily going to be looking at like 75% of 1 rep max or anything like that. It's going to be more about moderate intensity training, and I'll get into more specifics on that a little bit later. Initially, your exercise is going to focus on those low intensity intervals, and the progression is going to be based on your patient response. So even if you are feeling like you are keeping the intensity low and the patient is or should be tolerating it, if they are not, then the intensity is probably too high and you may need to reconsider what your interventions are. So the low to moderate intensity intervals, one of the best ways for you to gauge that is going to be with that Borg or modified Borg scale. So the Borg is the 6 to 20 and the modified Borg is the 0 to 10 scale. You might be able to calculate a heart rate and figure out what an appropriate training range is, but ultimately we don't really know for this population what an appropriate heart rate training range is. We're likely to see exaggerated heart rates, or if they're on medications that will blunt their heart rate, such as beta blockers, then that heart rate calculation is not likely to be accurate. So really listening to the patient's symptoms with an effort and dyspnea scale is going to be your best bet here. You're going to want to start with short duration intervals. So like Pam was saying, these patients fatigue very quickly. So you're going to be looking at, maybe they walk for 2 minutes and then they need to sit and rest for a minute. And how can you build up on that to improve their endurance? So if you're looking for a total activity time of 10 minutes of walking, maybe you need to split that up into lots of little chunks, and maybe you can't even do them all in a row. They may need to do a 2-minute walk before breakfast, and then a 2-minute walk in the middle of the morning, and then a 2-minute walk after lunch, and split it up like that. It's really going to be based on the patient's tolerance and what they're telling you about how they feel after their activity. To progress that sort of interval training, there's a couple of different ways you can do that. You can either increase the duration of the intervals, so maybe adding a minute to their walking interval, or if they are doing the intervals back to back, you can look at decreasing the duration of their rest breaks. So maybe they walk for 2 minutes and then they only rest for 30 seconds. Or you can add intervals. So if you're doing 6 2-minute intervals, maybe next time you do 7 2-minute intervals. The goal is to overall build up the time that they are doing aerobic activity, and that will improve their endurance. and then gradually start to sort of squish those intervals together until you end up with one longer duration interval. If you have the ability to do seated aerobic training, such as a new step or a recumbent bike, I strongly encourage you to consider that, particularly if the patient is presenting with that trunk muscle weakness. Having a way to support their trunk while they're exercising is going to allow them to work that aerobic capacity a little bit more without having to worry about supporting their posture quite as much. I see with my traditional pulmonary rehab patients quite often that their shortness of breath is significantly improved when they're on the new step compared to when they are ambulating. So that might be another option to get that aerobic training without being quite so limited by shortness of breath. Frequency of aerobic training ideally is going to be 4 to 6 days per week, and that's based on the recommendations that we have for other pulmonary patients, but also the general population. Ultimately, though, your patient may not tolerate this initially, and so you may need to think about whether you do very short durations, multiple days per week, or if you need to have maybe a rest day in between your endurance training days. And again, this is going to depend also on how frequently you can see the patient and whether or not the patient is able to do any of that training on their own outside of their rehab sessions. You're going to definitely want to educate your patient on their intensity expectations as well. So a lot of these patients may have been quite functional and independent before they got infected with COVID. And so their reference point for what is an appropriate level of activity for them, or what is going to feel easy versus what is going to feel hard, is going to be very different than what they may be experiencing now. So for some of these people, walking from the bedroom to the kitchen or that sort of distance may be exercise for them now. And that's a totally different mindset that they're going to have to adjust to than where they were before they got sick. Strength training, as Pam mentioned before, you really want to focus on functional training in these early phases. So what muscle groups need to be strengthened first to allow them to return to their daily activities and improve their mobility? So if they are experiencing that quad strength, sit to stands are a great activity. If they're experiencing more of that small muscle peripheral type of weakness, should you be doing kind of more targeted strength training like heel raises or plantar flexion, dorsiflexion? If they're experiencing that trunk weakness, should you be doing some more targeted core muscle training? Really, you want to figure out how can you make them the most functional, and then how can you train the activity that's limited? So if they can't get up off the toilet because their legs are too weak, then sit to stand training is going to be a very good option for them. Ultimately, you're going to want to focus on low weight, high repetition training. So we're trying to rebuild that muscle endurance, not necessarily create a lot of muscle hypertrophy at this stage. So looking at what is going to get them a moderate effort, doing about 10 repetitions, and then you're going to increase the repetitions before you increase the weight. The strength training should ideally be completed 2 to 4 days per week, but again, you're going to have to think about how often you can see the patient and whether or not there are activities that they can do on their own in between your rehab sessions. Impact of cardiovascular and pulmonary comorbidities. So some of your patients may have had a cardiovascular or a pulmonary condition before they got sick with coronavirus. So what does that mean for you? What other things do you need to take into consideration when you're treating them that are pre-existing before they got COVID? How are these conditions going to affect their recovery? How are they going to affect their exercise tolerance? And have these conditions worsened because of their COVID infection? Some specific ones to really think about, heart failure. So People who already have heart failure before they got COVID are going to be having a decreased ability to maintain their cardiac output potentially. And so you really have to consider as you're exercising with them, even if they had no cardiac involvement from their COVID infection, they may have a decreased ability to sustain that cardiac output. And what effects is that going to have on their exercise capacity and their activity tolerance? You're going to want to make sure that you're monitoring their blood pressure, because that's going to give you a lot of information about whether their cardiac output is sufficient for the level of exercise training that you're doing. Coronary artery disease, they may have a decreased myocardial oxygen perfusion. And this is particularly important to consider in light of what Pam was mentioning about their supplemental oxygen needs and also their SpO2 readings. So if we know that their SpO2 reading may not be representative of their PaO2, meaning that their SpO2 is reading higher than their actual oxygen levels in their blood may be, we really want to consider, should we be trying to keep those SpO2 levels higher in order to maintain adequate myocardial perfusion, myocardial oxygen. Pulmonary hypertension, a lot of these patients before COVID would need lots of oxygen and need careful vital sign monitoring. And that is going to be even more important now. So a lot of these patients need to have a higher oxygen level. Usually we try to keep them 90% or higher in order to prevent any hypoxemia related vasoconstriction in the lungs that could increase their pressures. And then really, really careful monitoring of their vital signs, because they can be very sensitive to even small increases in exercise intensity. Pulmonary comorbidities, did they have COPD before they got COVID infection? Do they have a productive cough? And this is particularly important to consider if the patient is still at that point where they may be contagious. And as Pam mentioned, we don't really know when they're no longer contagious. So you should probably assume that when you're working with them, they may still be contagious. So we may need to think about what airway clearance techniques can we use and how can they be performed to minimize exposure to other people, whether that's their family in the home or healthcare workers that are in the same facility with them. If they need help with that airway clearance, like if they need any percussion or vibration, how can you keep yourself safe while also making sure that you are providing them with the airway clearance that they need? And so for more details on that, make sure that you check out Annie Downs' presentation about airway clearance techniques, and that presentation is already recorded. Restrictive lung dysfunction. Many patients with restrictive lung dysfunction have high supplemental oxygen needs. And so if they had that before COVID and now they've had a COVID infection, those may build on each other and they may need lots and lots of oxygen, especially with exercise. So how do we monitor these patients and how do we make sure that they are responding appropriately to exercise? Vital signs are going to be extremely important. You should be monitoring vital signs before the patient starts exercising, after the patient finishes exercising, and a lot of times you may need to be monitoring them while the patient is exercising as well. The one that you're really, really going to want to monitor continuously, if you can, is that SpO2, so their oxygen levels. They may have a new supplemental oxygen requirement. They may not have been fully assessed for how much oxygen they need with various activities. That is our role to help determine that. So if you have the ability to continuously monitor with all the therapy interventions you're doing, that's going to give you some very valuable information about what levels of oxygen the patient needs for each activity. And that can be good for them while they're in rehab, or if they get discharged to home and they still need oxygen, so that they can have the appropriate amount of oxygen with each activity. Ambulation tends to cause a lot of hypoxemia. So just be aware that if you're doing strength training with your patient and their oxygen levels seem fine, and then you get them up to walk, you may need to turn their oxygen up, and you may need to turn it up quite high. The other things that you really want to consider with this is the accuracy of your oxygen reading. So making sure that you are doing everything you can to get the most accurate reading, even though we know that those readings may not be fully representative. The more accurate your reading, the better chance it is that it is close to representing their real oxygen levels. So thinking about temperature of the patient's fingers, if you're using a finger probe, are they wearing nail polish? Do they have any circulatory or skin conditions that are going to affect that oxygen reading? If you have access to a forehead probe, I would really recommend that you try using that, because that's going to help decrease a lot of that uncertainty with the reading that you may be getting with the peripheral circulation with a finger probe. Continuous monitoring, sorry, I wasn't quite finished with that one. Continuous monitoring of their oxygen level while they're exercising can also help them identify any symptoms that they have that correlate with low oxygen levels, so that they can help to self-monitor if they don't have a pulse oximeter readily available. Heart rate monitoring is also going to be very important. Deconditioning can cause an exaggerated heart rate response to activity. So if they've been very sick, or even if they've just been quarantining at home and mostly sitting on the couch, when they get up to move, that heart rate may go up higher, and it may go up faster, or more quickly rather, than it normally would if they had not been sick. And so you really want to take that into account, thinking about you don't want to put them straight into a higher intensity activity, because you don't know how that heart rate is going to respond. And definitely keeping in mind age predicted heart rate maximums. So if you're working somebody who's 20 years old, a heart rate of 130 may be no big deal. But if you're working with somebody who's 80 years old, that heart rate of 130 is going to be much closer to their age predicted maximum. And so you may need to tone back that exercise a lot, because 130 might be quite fast for them. The current best recommendation for age predicted heart rates is that 208 minus 0.7 times the age. And that has found to be the most accurate way to predict their heart rate, aside from doing a maximal exercise test, which obviously we're not going to be doing with most of these patients. The other thing to consider is that if they have any new cardiomyopathy from their COVID infection, do we need to be really keeping those heart rates down in order to allow that cardiac muscle to heal? Blood pressure, deconditioning, and bed rest can cause orthostatic intolerance. So are they dropping their blood pressure when they stand up? Do you need to consider things like compression stockings or education about positional changes? If they've had a new cardiomyopathy related to their COVID infection, are they able to get an adequate cardiac output? So this is when monitoring pre and post is going to be really important, because that's going to let you know if the intensity of the exercise is too high. If their blood pressure doesn't rise appropriately with the exercise, you may be exercising them at too high of an intensity, especially if you see a drop in that blood pressure. Dyspnea, or shortness of breath. The simplest way to measure that is probably with the 0 to 10 scale, and that's going to give you information about how the patient is feeling. You can also use a VAS scale that's just a straight 0 to 10. The modified Borg, I believe, has a little bit more research behind it for exercising dyspnea ratings, but you can use whichever one as long as you're consistent. Dyspnea ideally should be kept at a moderate to somewhat severe level or less. But again, this is going to be patient by patient, and you're going to have to look at the whole patient and not just the number that they're giving you for their dyspnea. Fatigue and exertion is going to be very similar. You can use the traditional Borg 6 to 20 scale. You can use a modified Borg or a VAS scale. Myself personally, in my own practice, I use the modified Borg for both dyspnea and fatigue because I find it's too confusing for patients to try to switch between a 0 to 10 and a 6 to 20 when they're rating their symptoms. The exertion, again, we're going to be looking to keep it at a moderate or less, maybe somewhat intense, but that's going to, again, depend on the patient and their presentation. Going back a little bit to what I was talking about earlier with what activities are now going to be exercised for the patient, the types of activities that are going to cause them to be working at that moderate intensity level are going to be a lot less than what their normal activities were before they got COVID. And so walking across the room may be a moderate intensity activity for them now, whereas before COVID, it was no big deal. You do really need to be careful that you're not overexerting and exhausting these patients. So really giving them those frequent rest breaks, making sure that they are not trying to push themselves too hard. They may not really have a good gauge of how hard they should be pushing themselves, and they may think that they need to push themselves really hard to try and get better, and then they end up overexerting and feeling exhausted, and they're not able to do anything for the rest of the day. And what you may find with these patients is that their shortness of breath may actually be more limiting than their fatigue. So you really want to make sure that you are addressing both the dyspnea and the exertion when they're exercising. So this is the modified Borg scale that I use in my clinical practice. You can see I use the same 0 to 10 for both breathlessness and perceived exertion. This is not a straight 0 to 10 scale. As you can see, it's got the 0 and then the 0.5 before starts at 1. The moderate intensity, which is kind of what we think of should be the middle of the scale, is actually at the number 3. I find that the color coding is very helpful for patients. And particularly if you have somebody who may have some of that cognitive deficit, providing them with different options of ways that they can rate their effort can be very helpful. I have patients who don't like to rate on the number scale, or patients who have difficulty reading the words. And so they'll say, oh yeah, I'm in the green range, or I'm in the yellow range. And so giving patients that option for different ways to rate their shortness of breath and their exertion may help them give a more accurate response. Self-monitoring is also going to be very important, particularly if you are giving them a home exercise program. So recognizing and interpreting their symptoms and what those mean and what they correlate to in terms of their vital signs is going to be very important. So doing that continuous monitoring with the oxygen levels is going to help you identify symptoms that indicate that their oxygen levels are dropping. And those are symptoms that they can then use when they're working on their own, especially if they don't have a pulse oximeter. Use of the dyspnea and exertion scales for exercise intensity are also really good for self-monitoring. They don't require any equipment. They don't require the patient to have a piece of like a bicycle or a treadmill or something that feeds them data. It's all about how they feel, and that allows them to monitor their exercise and adjust it accordingly. Vital sign monitoring is going to be a great option if the patient has the ability to do that. Manual pulse palpation doesn't take any equipment aside from a watch or a clock, but some patients really struggle with trying to find a pulse and with the counting. So that may not be an option for everybody. If they have a blood pressure cuff and a pulse oximeter available, make use of it. But if they don't, really helping them recognize and interpret their symptoms is going to be the best option. The biggest thing is going to be making sure that they are learning and knowing when it's time to slow down and when it's time to take a break. Breathing retraining is going to be very important for these patients. A lot of them may have never had any sort of trouble with their breathing before, and so this shortness of breath is going to be very new for them. We want to try to mitigate it as much as possible. So inspiratory muscle training may be a valuable tool here. People who are on prolonged mechanical ventilation may have inspiratory muscle weakness. They may have a lot of accessory muscle use to compensate for that. Restrictive pathophysiology, which is what we're seeing with COVID, can cause increased inspiratory effort. So you need to have stronger inspiratory muscles to expand those lungs. Inspiratory muscle training can also be a really great home exercise program once the patient has been taught how to do it and can demonstrate that they are doing it correctly. It's something that's pretty easy for them to do on their own that you wouldn't necessarily need to spend time in your rehab session doing. There will be a PACER project talk on inspiratory muscle training from Larry Kahlin. I don't believe it's been recorded yet, but be on the lookout for it. Pursed lip breathing is going to be a really easy and important technique here. So it's going to help slow down that tachypnea. As Pam was saying, we're seeing a lot of very high respiratory rates with these people. And so pursed lip breathing is going to help control that. It can also help improve gas exchange. So if your patient is desaturating, having them do pursed lip breathing is going to help bring that oxygen saturation back up again. Diaphragmatic and deep breathing, again, it's going to help slow that rapid respiratory rate. It's going to improve gas exchange, and it can also be a very powerful tool for decreasing and managing anxiety. Paced breathing is going to be where you time your breathing to the activity that you're doing. This is particularly helpful for energy conservation. And also helping patients slow down a little bit. So as I mentioned before, these patients may be not used to being limited like this. And so they may think that they can just get up and walk across the room, but in reality, they need to have something that helps slow them down, and really thinking about that breathing may be the technique that helps them there. This is also particularly helpful for anybody who has stairs to do at home. So I really encourage you to think about the paced breathing, particularly if they've got stairs or an incline or a ramp or something that they're having to do at home. There is a PACER project video on posture, breathing, and ventilation from Mary Massery, which has already been recorded, and I would encourage you to go and listen to that for more details about breathing retraining. A couple more techniques here. Paired breathing is going to be combining functional movements timed with the breathing. And Mary's talk goes into this in a lot more detail, so I'm not going to spend a lot of time on this, but some simple things like if you do shoulder flexion, so bringing your arms above your head, that's going to promote inhalation. Shoulder extension, bringing your arms back down to your sides, is going to promote exhalation. So you can use these sorts of functional mobilities to promote your breathing pattern, and they're also going to be helpful for keeping the rib cage mobilizing. And if they are having a restrictive pathophysiology, eventually the rib cage is going to become stiff if you don't perform some sort of intervention for it. Inspiratory hold and stacked breathing. These are going to be helpful to improve airflow and lung expansion, especially if the patient has experienced atelectasis. If they do have secretions that need to be cleared, these techniques can also be helpful to get air behind those secretions and help move them up and out of the lungs. But again, I would encourage you to go and listen to Mary Massery's talk about posture, breathing, and ventilation. She'll have a lot more details in there about the various techniques. Exercise tracking is going to be a very powerful tool for these patients in their recovery. So I would encourage you to keep a written log of exercises, either for yourself so that you can kind of monitor the patient's progression with their vital signs and oxygen use, but also for the patient, because this is going to help them see their progress. If you can show them on a piece of paper that when you started with me, you were only able to walk for 2 minutes at a time, and then you needed to sit and rest for 2 minutes, and we could only do that 3 times during your session, and now 2 weeks later, you're able to walk for 10 minutes without resting, that can be a really powerful tool for them to help keep them motivated and help them continue on with their rehab. This is also really important for when they are doing their home exercise program. It's going to help keep them motivated. If you are working in home health, or even when you get to outpatient, if you give the patient an exercise log and have them fill it out, that's going to be a good commitment device to have them actually complete their home exercise program. Setting goals. So goals should ideally be function-based. Not all of them, but you should definitely be addressing function-based goals. So things like the patient will ambulate independently 150 feet with the least restricted device to demonstrate the ability to mobilize in the community. So you want to look at quantifying their endurance, like Pam was talking about before, whether or not they need a device, whether or not they're going to be able to do it independently. And then ideally you want to link it to something that is functional, or that is demonstrating that you are helping them return to their prior level of function, like ability to mobilize in the community. You can also create goals around hemodynamics. So a lot of these patients have new oxygen needs. So can you create an appropriate goal around their oxygen? Particularly if you're trying to wean them off of the oxygen or wean them down to the level of oxygen they had before they got COVID. How can you set that goal such that you are addressing their oxygen level with their activities? So patient will maintain their oxygen levels 88% on 2 liters during ambulation 50 feet to demonstrate the ability to safely mobilize in the home. So this could be a very appropriate goal for a subacute rehab setting in order to demonstrate that the patient is safe to go home. Incorporating self-management techniques into goals is also going to be very helpful. And this goes along with doing home exercise program type goals. So you want the patient to be able to implement strategies independently that are going to manage their shortness of breath. So you can do that like I have written out here, or you can look at other home exercise program type goals, like patient will be able to appropriately maintain their endurance level at a moderate intensity for X number of minutes of ambulation. Utilizing standardized outcome measures in goal setting can also be very helpful. So like if you do a 6-minute walk test, looking at MCIDs for that. There aren't any for COVID, obviously, but there are ones for ARDS and COPD, so you can look at those age predicted norms for other outcome measures like the sit to stand or the step tests. Patient goals. So don't forget to find out what your patient's goal is. If you make all of these great goals for therapy and then you find out that the patient wants something completely different, then your goals are going to be hard to achieve because the patient's not going to be on board with them. You may have to really talk to the patient though about what is a realistic and achievable goal, because they may think that they are going to be able to get back to exactly how they were before they got COVID, and that may not be a realistic or achievable goal, or at least not an achievable goal while they're in therapy. The other thing that you really want to try and encourage them to do is to establish a concrete goal that you can say, yes, I've achieved this. So saying something like, I want to be able to walk to the mailbox and back without having to rest is going to be a much better goal than I want to walk more. So if somebody just says, I want to walk more, that's not quantifiable. You can't say when that goal has been met, versus walking to the mailbox and back without rest breaks is something that you can say, okay, the patient did this, they've met that goal. Involving other disciplines is going to be something that could be very valuable for these patients. So oftentimes we as PTs, and also for our other rehab colleagues, OTs, speech, we're often the ones who sit down and really talk with the patients about their longer term goals, and we're the ones who have the time to do that. So we may be the ones who are really figuring out what other things does this patient need now that they're out of the acute care hospital and they are no longer critically ill. We may need to request additional services for them, particularly if you're in the home health setting. They may have gone home with just a home health PT referral, and now you're the one who's having to figure out everything else that they may need. And of course, your resources and your needs are going to vary depending on what setting you're in. If you're in home health versus LTAC versus outpatient, what you have available and what the patient needs in those settings is going to be different. Some specific disciplines to consider that would complement their rehab would be occupational therapy. So ADL training, if they were driving before, are they going to be safe to return to driving? Are they needing to figure out if they're going to be able to return to work? Speech therapy can be very helpful for cognitive function, but also if the patient was intubated or had a tracheostomy while they were in the hospital, are they having swallowing deficits? Do they have a trach where they need to have speaking valve training? Do they have cognitive deficits that need management? Respiratory therapy can also be very helpful. And if you are working in an LTAC or a subacute setting, you may have access to a respiratory therapist to talk to the patient more about their new inhalers or their oxygen use or their CPAP or BiPAP if they have one of those. I'm very fortunate in outpatient pulmonary rehab that I have a respiratory therapist who's available to me for my patients. So if you have that, I would definitely make sure that you are taking advantage of that resource for these patients who have new respiratory complaints. Dietitian is going to be somebody that you're going to want to consider for these patients. They are likely to have new caloric needs. They may need a high protein diet for that muscle recovery. They may have a new diet restriction. Maybe they are only allowed to have thickened liquids, or maybe they need to have a soft diet now, and they may be having to figure out how they can make nutritious meals based on those new restrictions. Counseling and psychiatry may also be needed. Stress management and coping skills, particularly if the patient has been in the ICU, they may be experiencing PTSD, new anxiety, depression. And so for details on that, I would have you go and listen to the PACER Project Post-Intensive Care Syndrome presentation that Pam mentioned earlier with Patricia Otaki and Jim Smith. Education. So we are fortunate as physical therapists that we generally have time to educate our patients, whether that's while they're on the new step or while they're sitting and taking their rest break. We have these opportunities to educate them as we treat them. So you don't necessarily need to do a sit-down formal education, but think about the things that the patient needs to know that you can teach them while you're working with them. So appropriate use and titration of their oxygen. Particularly if they are brand new to oxygen, they may not even know where to begin with that. They may not even know the right way to put their nasal cannula on. Ellen Hilligus did a talk about vital signs, exercise, prescription, and oxygen devices. So especially if you are not as familiar with oxygen devices, I would definitely go and listen to her talk. Pacing and energy conservation techniques. How can the patient get through their day, and how can they make adjustments to allow them to do more during the day? I'm going to get more details on that in just a minute. Home exercise program. What can they do on their own, particularly if you are not able to see them as often as you would like? And then breathing retraining. We talked a little bit about that already. And again, I would encourage you to go and listen to Mary Mastery's talk on that. So energy conservation techniques. One of the biggest things that patients can do to conserve energy is to complete ADLs and IADLs in sitting. So shower chairs are going to be something you really want to consider for these patients. Encouraging them to brush their teeth or shave sitting down, dressing sitting down. Meal prep, take the vegetables to the table, sit down and chop them at the table, and then bring them back over to the stove instead of standing at the counter to chop the vegetables. Using assistive devices to avoid bending. So shoehorns, grabbers and reachers, sock aids. Every time the patient bends over, particularly if they have that poor trunk control and muscle weakness, is going to be a big effort to come back up, and that's going to drain their energy. Making sure they build in time for rest breaks. So if they're rushing to get through something and they feel like they need to finish it before they can stop, they're going to feel a lot more exhausted than if they had given themselves time to rest in the middle. And that goes along with completing activities in short bouts. It can be helpful to sort of plan the activities out so that they can say, okay, I'm going to chop all the onions, and then I'm going to take a rest break, and then I'm going to come back and I'm going to chop the carrots, and then I'm going to take a rest break. Whatever it is that they're doing, help them to figure out how they can divide it up such that they can complete one piece at a time without becoming too fatigued. And then encouraging them not to try to pack too much into one day, particularly in the early stages of recovery. But then also, as they're starting to feel better, they may feel like, oh, I have more energy today. Let me go and do all of these things that I've been putting off. Let me go rake the yard and plant the flowers and walk the dog. And before they know it, they've done too much. Home exercise program. Again, this depends on where you are and what practice setting you're in. But if you're not able to see that patient 5 days per week, is there something that they can do on the days that you're not working with them? One thing to really consider, though, is new supplemental oxygen requirements, particularly if you're not sure yet exactly how much oxygen they need with each activity. Don't give them anything that you haven't already done in rehab and made sure that they are safe and that they can appropriately titrate those oxygen levels for that activity. Start small. They might think they can do more than they can. And like I said before, you don't want to overexert and exhaust. So make sure that you are giving them an exercise program that is appropriate and challenging, but not to the point that they are overexerting. Thank you all for listening to this webinar presentation with Pam and myself. We would also like to thank the cardiovascular and pulmonary section of the APTA for initiating and coordinating this project. It's been a huge undertaking, and we really appreciate all of our colleagues who have donated their time to create these educational webinars. We'd like to thank the APTA Learning Center. For all of you who are not yet aware, these videos will all be available on the Learning Center for free CEUs, both for APTA members and non-members. And thank you also to all the other sections and academies of the APTA for participating and supporting this project. This is not just a cardiovascular and pulmonary section project, and we really appreciate all the collaboration from the other sections and academies. And here are some additional references for you guys from my section of the presentation.